So triaging in any setup helps us in early identification of potentially lethal condition and extensive resource utilization. So let's see what happens in geriatric triaging in emergency department. May I welcome Dr. Madhu Srinivasarangan, Associate Professor, Department of Emergency Medicine from JSS Medical College to moderate the session. Over to you, sir.
Thank you, Danya. It's a pleasure to be here. I'll just take a minute to introduce the topic. There is the idea of geriatric emergency medicine and triaging in the geriatric emergency is not very new. But with the advent of emergency medicine departments in most medical colleges, NMC recognizing it. In fact, I think emergency medicine and geriatric medicine are sister specialties in that way. We were born together, we grow together. It is becoming more and more evident that from the point of view of quality also, if you can have standardized approach and if you can have measurable outcomes in an emergency department, you can improve quality. And from that point of view, I think this is an apt platform to discuss triaging in the emergency department. Currently, we see emergency departments can look at a patient and consider disease severity. We have various scores like the Manchester trauma triage score or the emergency severity index, Apache for a more detailed scoring system, or the modified early warning scale or the Mu scale. These are something that can be applied, but they don't take in, while they take into consideration disease severity, they don't seem to take into consideration the fact that elderly have separate problems. So for this, we may have various other existing geriatric vulnerability scores like the identification of serious at-risk score, triage risk stratification tools, fall risk scores, what were detailed earlier by Madam in the previous talk. So there is a need it is desirable to decide who among the subgroup. It is very intuitive. We can say that patients who come to the emergency department, among them, the elderly are likely to have worse outcomes. It is very intuitive to say, but it would be nice to know who among these have the higher risk, so that perhaps once we are able to do that accurately, then perhaps we can divert hospital resources, or we can even consider that this is a person who has an unsurvivable pathology, and we may take a more non-aggressive approach in such patients. And to enlighten us about how we can put these things together, we have a professor from Christian Medical College, Vellore, who is the apt person to speak about this. I believe she has built up the emergency at the geriatric department at Vellore from an acute care facility to involve preventive, promotive, as well as the rehabilitative aspects of geriatric care. She is an editor of the Journal of, she's the editor of the Journal of Indian Academy of Geriatrics. She is a member of a core group. This is her academic credentials. She is a member of the core group and medical education department of the NMC Nodal Center at CMC Vellore. She has started several fellowships and teaching courses. She is established proper liaison with our sister departments, orthopedics and vascular surgery. She reaches out to the community through the works of CMC Vellore, the RUSA clinic and the clinic at Chittor. She organizes regular CMEs and has been the organizing secretary and chairperson of the annual geriatric conference, GeriCon, in 2011-2019. It is an honor to invite Dr. Surekha to kindly deliver her talk. Ma'am.
Thank you at the outset for that long acknowledgement of what I have done in the past, and thank the organizers for reposing their faith in me to try and cover this topic, which I have actually never gone into, is the emergency department and versatile geriatric triaging in the emergency department. Patients aged 65 years and older present to emergency departments worldwide with complex care needs that are not suited for this fast tracking in the emergency department. Emergency department presentation has been identified as a sentinel event for older people. Your antennae should be up once an older person has actually come and presented to your department, a time when immediate medical problems can be assessed and risk factors assessed and managed to reduce basically future adverse health outcomes, which we'll come to later. Emergency medicine physicians require accurate and sensitive information function to appraise the patient's status. So functional status of a patient pre this particular test is very important, and they have to make decisions either admit or discharge to community. If discharged to community, do they need more help there? Do they need something else to keep them safe in that community? I'm sorry to all emergency physicians. I salute them. They do a good job. But what they do is a set of criteria, which they do a check 1, 2, 3, 4. If it's not there, you go to the community. If it's there, 1 or 2, you either go to the ward or to ICU. That's how they triage the patients. Our patients present to ED, to the emergency department, with the following acute illnesses. Definitely very, very acute illnesses. But underlying these illnesses are a host of other problems which are actually difficult to get a history of at the first time and to address as acute care. So therefore, clinicians are advised to look at the patient as a whole rather than relying on specific parameters to make clinical decisions. So we have to actually, all emergency physicians should look at geriatric syndrome, which involve underlying cognitive impairment, mobility impairment. One huge thing that's coming along is frailty, falls, incontinence, and depression, which run rampant in this particular vulnerable group. How does the emergency room assess priority for patient care in the hospital? The triage depends which groups of patients should receive treatment and care based on, first of all, the clinical status, the ABCDE, the prognosis of the disease. They have underlying cancer, terminal illness, terminal COPD, terminal CCF, or available resources. This is very important in our resource constrained environment that we work, where we have less beds and less money to actually look after our patients. To ensure that this vulnerable population receives appropriate attention in a suitable location where they are safe with a requisite degree of urgency, and not say they're old, they can go home. They're old, they can just stay in the ward or just sign a do not intubate, do not resuscitate paper. So decisions to admit or discharge from the ED are generally based on the patient's risk of suffering a short-term or long-term adverse outcome. And this is what ED, the emergency department, is looking at: cognitive impairment, functional decline, in-hospital mortality, and institutionalization. And long-term, to see that the patient doesn't come back for readmission, because that's a really bad word. That means we haven't actually treated or assessed the patient correctly, or 3 to 12-month mortality. Again, institutionalization, no patient likes to be in an institution. They love to be in their own homes. So based on a lot of things, many people color code them into either 5 different colors, where red is and needs immediate evaluation by the physician. This can be made at the door by the triage nurse or somebody who's trained to do it. And blue has minor injuries. In our priorities, we have 3. Priority 1, which is very sick and needs urgent care. And these are the conditions for that. There's priority 2 and priority 3 who can wait for some time. Sometimes it can go on to us because there are people in priority 1 who need urgent, immediate attention. This actually you would have heard when you were doing COVID. That's the news score, news 2 score. And it tells us about the respiratory rate, the pulse rate, the systolic blood pressure, the level of consciousness, the temperature, and the pulse oxygen saturation. So if you use the news 2 score, it is statistically significant but poor in accuracy in predicting 30-day mortality in this vulnerable population and HDU admission. And it's not, this is statistic significant, but it's not at all significant, and it's very inaccurate for the emergency length of stay or revisites. It may predict hospital admissions. So in all these scores that I'm going to allude to now have certain discrepancies and the limitations, and they need to be actually refined to suit a vulnerable population. So I was mentioning about the emergency severity index, but it's level 1 to 5, which I have mentioned before, red to. And first level needs immediate medical care. I mean, there's no way you can ignore such a patient. And levels 4 and 5, care within 30 minutes. Basically, the ESI, the emergency severity index, is to decentralize medical care. So in a study, the ESI algorithm performed well using ED resources, ED length of stay, hospital admission, and 1 year survival. So this is a good score when it predict for these particular predictions. The others regarding 30-day hospital mortality, things like that are not very significant. There's an ISAR score. Many of you all would have read this when you look at geriatric triage. ISAR is the identification of seniors at risk. This has a little more geriatrics built into it. Before the illness, did you need someone to help you? After the illness, did somebody help you? Things like that. It's a very simple score, and a score of more than 2 indicate that these people can be more at risk. When they're at risk, you have to actually again triage them into something called the systematic evaluation and intervention for seniors at risk. If you the next slide will show you how they score these people. Basically, if you need evaluation and intervention, they need to be either admitted in the hospital and a huge assessment to go on, and or they can be released from the ED and have people going in to see them, or appointments are given from primary care to see different consults. This is the SSR score. You can take it from Google. So I'm not going to allude to that much more than this. The ISAR score predicts risk of hospital admission, readmission, longer hospital stays. Mortality up to 6 months, predicts more frequent return EDs and use of community services. So it's actually a better score than the new score that you just saw, which just said acute presentations. This again is one score that they use, that same thing, it goes upon presence of cognitive impairment, gait disturbance. Actually, what you're looking at is more and more of geriatric giants or geriatric comorbidities that they usually use. So what ma'am was saying about polypharmacy, then you have cognitive impairment and gait disturbances. This is called the triage risk screening tool, and it identifies baseline functional impairment, can predict subsequent functional decline, and the TRIS may be useful in identifying high-risk patients who would benefit from referrals for further evaluation or surveillance upon ED discharge. But both these scores put together are comparable. They only are moderate in accuracy and slightly higher sensitivity and lower specificity. So it's not that very good, but there is some improvement over the new score. They have also done the TRIS score and the rapid geriatric screening score together, and they have said that compared to subjects who receive standard care and those who were using the TRIS and received the rapid geriatric screening had better preserved function a year after index ED. Intercapacity is another word that we use very often in geriatric. This actually improves those things. So what's coming through is a rapid geriatric screening or a comprehensive geriatric assessment is required in these patients to actually improve a lot of readmissions, in hospital mortality, morbidity, institutionalization, etc. All the other instruments that I have mentioned here, just think who have immediate life-saving intervention. They were not able to stratify high-risk patients, and a significant number of patients who were not at risk were falsely identified at risk by the variable indicator of placement. So all these instruments have not been actually showing my patient what my patient needs. These tools do not take into account socioeconomic, because they were all done in maybe places which have an NHS service or something like that. Health literacy, how disabilities and illness severity of the older person. They have so much limitations that we can't actually use these scores suitably. So what do we need? We need to evaluate, first of all, validate these tools and newer tools, and continue this process should continue due to an increasing number of older adults utilizing ED services. The geriatric multidisciplinary team, that is very important. I'm introducing this term to you all because multidisciplinary team should be in casualty to look at these people who will remain at the forefront of geriatric assessment in the ED, and an important stakeholder in continuing to refine, develop, and test evidence-based protocols in a safe and quality care at risk older individual now and in the near future. So we need a team who will actually look at the geriatric patient differently. When you have an acutely presenting older person, There's a screening to see if it's low risk or high risk. If it's high risk, or we'll have to look at his nutrition, the bed, the family, the exposure to daylight and his environment. Does he need hospital admission or discharge at home? But if he needs hospital admission, the family should be actually educated. A complete geriatric assessment has to be done. And if he's discharged home, you must communicate to the doctor that he is going to buy either a discharge slip or a phone call. Follow-up is very important with these people. We normally do a Barthel index. This is for actually looking at functionality. And wherever there's a problem, like if he has a problem with mobility, if he has a problem with the feeding, we put extra help in. How do we put extra help in? Nowadays, there are home care facilities which actually provide this help, or we teach the carer before the patient goes home, so the patient can actually go home to a safe environment. The tools that we use, whatever they may be, should not be used as the sole instrument in predicting adverse outcomes. We have to mend the tattered emergency department safety net for these vulnerable old patients who slip through these nets because they can't tell you what's wrong with them. Their symptoms so atypical. Sometimes it's difficult to find out who is the sickest, a man who's quiet and sleeping quietly, or the one who's jumping around and saying, I need help, I need help. Disease-specific prognostic instruments should be incorporated in the overall assessment in order to be more effective in identifying patients who are likely to experience adverse outcomes. So we have to actually look at underlying disease. And this is not just disease, it is diseases that may interact with each other, drugs which may interact with each other, and have a bearing on the acute presentation of this particular patient. Include the patient's preferences and choices when making healthcare decisions. You are not the person who's going to give judgment. The patient and family are important in assuring that we reach a common goal. Ensure that the interprofessional team members work towards the same patient goals. And dedicate high quality discharge education, whether it's from casualty or from the ward. We need to know my patient is safe with adequate nutrition, with rationalization of medication, and with mobility. The environment is good that he's returning to. Educate the community of potential adverse outcomes of older adults. So look at environment, look at NGOs, look at other people who will help these patients. Finally, it is the most vulnerable who will have the most to lose from systems that are unsafe or inadequately designed to address their needs. Please remember, we have to actually up our antenna and also look at our systems. There are pediatric ICUs, there are trauma ICUs, there are so many ICUs. Why not a geriatric? Especially since geriatrics is going to be a real huge number of people in this particular strata of society. Radical redesign may be necessary to help health services provide safe and sustainable patient-centered care, because they, the geriatric people, have given so much to us. We need to give back to them in the same or a more measure. So how do you radically redesign this? Greater provision of acute geriatric assessment in ED. So we're asking for beds in ED, and that's called interface geriatric. So if you have just beds in the emergency, it's not enough. It's a team in ED who should be there. You can't expect a person whose vitals are really very unstable. The emergency department physician runs to them. They have to, because he's a red alert for that. But you can't expect them to come and take a detailed history from our geriatric patient when somebody is nearly dying. So we need something like this to happen in the emergency department. The access to allied input. Actually, now we have a social worker in the emergency department to look at some of the things that are socially required. Can they afford this treatment? Things like that. And strategies that will provide safe alternatives to admission. We have to look at that, because not all patients in that age group want to get admitted. But are they safe being sent home? So work with the carers, because they can give you information regarding how the patient was, what the patient likes, what the patient loves, and basically the patient's life. That's what you have to do. So use all these systems. Don't rely highly on tools. Look at the patient holistically and enjoy working for this particular vulnerable subset of population who are usually ignored by the whole view of the CD. Not that I'm putting down anybody who works CD. I salute all of them because they're doing a really good job. I wouldn't last in acute care for more than 1 hour, I'm telling you. These have done a good job, but I guess we have to rethink whether we need a geriatric, a separate ED or a triage system or 10 beds, as I said in an meeting. Thank you.
Thank you so much, ma'am.